Welcome to the Geeta Chopra Show. This is your time to heal naturally. Embrace nature's healing energy. Get back in tune with your higher self through yoga, meditation, healing foods, living in balance, healthy relationships, and harnessing the true power of prayer. You are powerful, you are loved, and you can do it. I am Geeta Chopra, and let's heal together, naturally. My first guest, Elise Berry, is CEO of the New Jersey Pharmacists Association. Elise is an accomplished association executive, and she has extensive experience in nonprofit management within the fields of healthcare, real estate, historic preservation, and planning. She assumes responsibility for initiatives of significant scope and delivers results with the highest standards of integrity. Elise is a graduate of Boston College, and she holds a master's degree from Pratt Institution. In addition, she earned a postgraduate certificate in nonprofit management from New York Medical College. My second guest, Ruth Marietta, past president and past chair of the Board of Trustees of the New Jersey Pharmacists Association, joins us. Ruth is a practicing community pharmacist. She has experience working in hospitals in the retail setting, and Ruth is passionate about helping to educate folks about drug abuse, drug prevention as well. She has been a member of local drug abuse prevention groups and alliances for years. Ruth has also been a guest speaker about the opioid epidemic on the Bronx Radio Show at Rider University in 2016. With her involvement through the NJPHA, Ruth was awarded the Cardinal Health Champion Prescription Award, recognizing her community work against drug abuse. She served on the Medical Education Committee for the Pain Council to the New Jersey State Board of Pharmacy in 2016. Ruth served as president and then chair of NJPHA from 2015 to 2017 and continues her work on drug advocacy. So, ladies and gentlemen, I am sure you're going to enjoy this episode immensely. We will discuss the opioid crisis in detail and what you can do, as well as the public, to manage this crisis from a much better perspective. Welcome, Elise, and welcome, Ruth, to the show.
Thank you, Geeta. We appreciate the opportunity to be with you here today.
Oh, it's great to have you. Thank you. All right, so let's get into our questions here. I can start with you, Elise. What comment does the New Jersey Pharmaceutical Association have on the opioid crisis?
Well, it's interesting that you introduced us that way. We were originally the New Jersey Pharmaceutical Association. We're one of the oldest state associations in the country. We began in 1870, and at that time, that was our official name. But in the 1990s, we changed it to the New Jersey Pharmacists Association to be more representative of the people who are our members, which are the pharmacists in the state, and also to distinguish ourselves from the pharmaceutical manufacturers, because that's obviously not what our primary mission is. And where our mission is to help the patients that come to the pharmacists for their expertise and advice. But one of the things that has been well known throughout all of this is that the pharmacists are involved, certainly in opioid management, but the pharmacists are very well trained, and the pharmacists have a high degree of education in not only anatomy and biology and chemistry, but botany and toxicology, and so they are the medication experts. And really, I think pharmacists generally want to be involved in being part of the conversation with the physicians and the patient to help them manage their pain when they have it, or at any time when they have to take any opioids for their treatment. So one of the things that happened, I mean, everyone knows that there's a crisis now,
yes,
all across the country. And there are stories of families that have suffered greatly, people who have died because of it. And it became evident to us that some of those interactions could have begun very simply as a sports injury, or it could have been a trip to the dentist, and it just snowballed into an addiction that's very hard to manage and very hard to address.
Sure.
So the New Jersey Pharmacists Association has a professional affairs committee, and we look at some of these professional situations that develop, emerging trends and things. And one of them was to try and address the opioid crisis. So unfortunately, our colleague, Dr. Carmela Silvestri, was not able to join us today, but her area of focus was, since she was our 2018 president, she convened a task force to deal with this particular issue. And we looked at it from 3 different areas. It was to look at it from a research perspective and the science behind addiction, to look at it from what the community practitioners see, those who see the patients in their stores, those who counsel patients maybe in a residential treatment facility or in a nursing home, or they have interaction with patients in a hospital emergency room, for example. And so it became evident that we wanted to be able to find other solutions that would involve pharmacists in this.
Now, what are some of those solutions? What are they actually doing to address this problem?
Well, I think Ruth can probably talk on about the community level, but certainly there are, nationwide, as I mentioned, there are all kinds of studies underway to try to address this. And there can be, for example, in an emergency room, there has been evidence shown that if medication-assisted treatment is begun in an emergency department, the individual who undergoes and agrees to that treatment seems to be able to maintain their involvement in the treatment longer than if it's sometimes started in other practice settings.
Sorry, can you clarify that? So you're saying that the individual would take the responsibility to maintain their treatment protocol? Or
in part, yes.
Okay.
But it seems, and I think maybe because, and this is just subjective on my part, but it could be because they're in an emergency crisis situation and they might understand that they're at risk a little bit more than they do maybe at other times during an addiction. And so they are more willing to accept
But how can they do that as the individual? And by the way, you both have remarkable biographies and you're very well informed, so I think this will be a very healthy discussion. But how can somebody who is, or how can a human being resist that? Because they're prone to that, right? The actual nature of the opioid is addiction, you know, to get that pain-free feeling, whether it's physical or even mental, you know, when they take antidepressants. So how can they come in with that perspective that, well, I'm not going to be addicted?
Well, when they're in the emergency department, they already are in a crisis situation.
Yes.
So that's when this medication-assisted treatment is sometimes initiated, and that is there seems to be more of a likelihood of continuation in that treatment program because I think they've faced that crisis.
So if they get into a car accident or something, so you're saying those kind of ER patients? Or
someone who's there for an overdose.
Okay, so you're speaking
yes,
overdose.
Yes, I'm sorry, I wasn't clear.
Sorry.
Yes, yeah.
Okay, okay. So,
yes.
but what about the guy who got into a car accident or someone who's just in grave pain? So how would you address that, Ruth?
Well, that would be considered treatment of acute pain
Okay.
for somebody that is in a car accident.
And would that be the painkiller or the opioid, rather?
Well, it depends on the severity of the car accident. If it's something major, then the physicians will come in and make an assessment to see what type of treatment plan they're going to, you know, prescribe for that particular patient.
So would it be temporary, like a painkiller for the acute part of it, and then ongoing something else, like physical therapy or some sort of self-healing mechanisms?
Well, like I said, it depends on the type and the severity of the accident. Somebody that's more severely injured would, you know, possibly be hospitalized and then be given pain treatment in the hospital, or somebody that has a very mild injury might be released on, you know, a short-term acting opioid or an anti-inflammatory, depending on the nature.
And who would recommend this? The doctor in charge at the time?
The doctor,
Okay.
yes.
So, I mean, and the reason why I'm really getting to detail here is because of the ongoing opioid crisis, as we all are aware of. So if you're saying that the long-term treatment might be a shorter or a less severe painkiller, why would it be that and not something like physical therapy or some natural, I don't know, painkiller, anti-inflammatory, something or the other? Would it always be the opioid, or would it?
I think it's safe to say that it depends on the situation.
Okay, because more often than not, they're opting for that, and that's part of our problem.
Possibly the person still has more pain after it's expected in an acute injury. That would depend on, you know, the physician. I mean, there are other pain treatments that can be assess for people, they can have physical therapy.
So what are the safer alternatives to painkillers?
It depends on the severity of the pain.
Do we have an example of any? Or
Well, we have anti-inflammatories that are on the market that can be used. That could be a first line, depending on the type of injury.
So as an alternative to a painkiller? So
yes.
like an NSAID or something?
Like an NSAID.
Okay.
There's physical therapy, like you said. There's other things, that could be prescribed. And it doesn't have to be an opioid. There's other medications that are not considered an opioid to, to start out with.
So what are some of those? Are we familiar with those, or are those a little bit more advanced pharmaceutical products?
One of the milder ones is considered Tramadol.
Okay, so that doesn't come with side effects or anything like that?
Every drug has side effects.
Because I think that's given to cancer patients. That's a pretty strong one, right? Or
Tramadol is not considered that strong.
It's not, okay.
The oxycodone, oxycontin, hydrocodone, morphine.
Okay, so they'd come down from that to the Tramadol class of drugs. Okay,
right.
And then kind of wean off, or would they not be able to wean off the Tramadol?
Well, I think every physician would like their patient to be weaned off.
Yeah, sure. Yeah.
Especially now, like with the prescribing laws, that the first they have to be prescribed for only 5 days.
I mean, and what about the acute pain? Because sometimes people will come to the doctor and they say, well, I have this terrible pain and I just can't bear it. What if they can? What if they can, or they're encouraged to just, I guess, undergo short-term discomfort? Because sometimes people exaggerate their symptoms, right? And that's how this whole thing starts.
Right.
Or maybe they just want drugs, and that's why they come in. So how can you distinguish that?
Everyone has pain at different levels.
Yeah.
What may be very painful for you may not be very painful for me, or vice versa. So the doctor really has to take the assessment of the patient in general and determine what they feel in their clinical estimation is the best method to start that patient. It may be something that they go up. They may try one medication that's a lower level, as Ruth mentioned, and maybe they feel they have to go up because it isn't achieving the goal for the patient. But I think also if you have an acute situation such as an accident, as you mentioned before, it's combined with a physical therapy afterwards. You may be on pain medication or some form of that sort of treatment for a period of time, and then you start to work into a physical therapy or occupational therapy if that's what's needed.
Well, I mean, there's like a 2 or 3 or 10-fold problem, associated with this. So whose responsibility is it to kind of advise the patient that if you take this, then this, so the addiction can be long-term, or that you must try physical therapy within the 3rd week of this? So who does a burden lie upon to prevent all this? Like, should there be a counseling service from the doctor to patient? Should it start at the pharmaceutical level? Should the patient come in knowing this? So how do we actually address the root of this?
I think the physician is the first line person who would be advising and counseling and treating the patient, in that manner, and kind of assessing as they go along.
Okay. So is it more the doctor who just wants to mask symptoms, or do you find it's the patients who are coming in and saying, we just can't bear this pain, give me a drug? So is it, which side is it more on, or both?
I can't speak for that because I don't really see that in action, but I can only speak for what we get in the pharmacy. The pharmacist can be checking, certain things like a patient profile or the
because you can't really
PMP.
tell sometimes.
Right, we can't really tell,
Sure.
and we don't always know what type of pain the person has. We can actually ask patients that if we suspect that there's being used longer than what we think of, it might be more chronic pain. And we can have discussions with the patient themselves. Pharmacists, will talk to the patient and try to counsel them and assess and find out what type of pain they have, and then also discuss with the doctor. We do that in practice as well. We call up the doctor if we suspect that somebody might be on pain medication for way too long, and
But aren't most people, or what majority of people are taking it for longer than 6 months? Isn't that typically the case, or?
I would have to say patients that have surgical procedures might be on pain medications for longer than.
Now, is that because of the addictive component, or because of the need? I mean,
because of the need for the pain.
But that could be kind of a gray area too.
Right, and along the way, that's when they could become addicted.
Right, so there's a great inherent risk in these things.
Yes.
How do you address patients who just want to mask symptoms?
Well, I think that certainly the doctor would be the first person to make that call as to whether the patient was masking symptoms or exaggerating symptoms and so forth. If they're masking symptoms because they're in that much pain, it's obviously chronic pain, and there has to be some root cause. If the cause is identifiable, the physician would address it or refer them to someone who addresses that particular kind of pain. There may be people who have back pain, for example. That seems to be a fairly common complaint, and it may be chronic, and it may be they may have had surgery and it didn't bring much relief, and they may have had other treatments that didn't bring much relief, and so they may need to have chronic pain medication. That's when there's a pain management specialist involved, and that individual has a contract between the doctor and the patient to say, you know, I will follow these guidelines. I have this pain, and what they're trying to treat, and then the pharmacist is there to support what the doctor's treatment plan is. No matter what medication you're taking, whether it's an antibiotic or if it's a pain medication, they're doing it to try to support the treatment plan that the doctor has developed for the patient.
Okay, so it starts with the doctor, but it can be erroneous as well, right? Because like you were saying, the doctor may not always know how much pain the actual guy is in, or, you know, exaggeration, or everyone has a different threshold. But it is still one size fits all, more or less. If someone's if they're depressed, we give them antidepressants. So that's how it is, right?
Correct.
So let's speak to some of the side effects here of, I guess, antidepressants we can take out. I know this show is more about the opioid crisis, but the antidepressants, you know, they do have side effects. We don't need to reiterate them here, but there's a whole list of them. So how would you address that, or being from the pharmaceutical industry? What can you say to that?
Well, we always counsel patients on any medications that they take, particularly for the first time, and the patients always get an educational sheet that goes along with them, but mostly what we'll do is we'll discuss the major side effects, or, you know, what to look out for, and drowsiness is one of them, and it depends on the antidepressant.
And some of them are way more severe, right?
Yes.
Like for the organs and all that.
Yes.
So in a sense, it's like counterintuitive. That's what some of the younger population is saying now. Because of the side effects, they're almost creating the same problem, like repeating the problem. So there's a huge group of people who actually believe that.
Right.
Yeah.
Well, it's important to remember that every drug does have a side effect, no matter what class it's in, even an antibiotic.
Okay.
So.
Well, I mean, I guess on that note, would the pharmaceutical industry ever focus on prevention rather than addressing symptomology?
Well, we're not the pharmaceutical industry, so we can speak from the pharmacist's interaction with the patients. They're certainly in favor of helping the patients to achieve the positive outcomes that they wish to achieve. I think that the medications are there for the purpose of treating some kind of illness or some condition that can't be treated in other ways for that particular patient. So, for example, if you need an antibiotic, you need it for a short term, but you need it. And you take it, and then your body will recover. But it helps the body along in its recovery. And that's part of what the medications are meant to do. There are occasions, such as you've described, where it does become chronic or it does become long-term, and those are rare cases. I mean, how many people would you say come into your pharmacy and they get their medication, they achieve the goals that they're trying to achieve, and you know they're fine till the next incident, whatever that incident might be?
That's correct. I mean, it's a small percentage, and it's also important to note that with any drug, as I said, there are side effects, but the side effects aren't in like a high percentage. So they're more on the low percentage, and that's a function of the government and putting the drugs out on the market. If they feel that something is noted that's in a high percentage, that drug may not even make it to market.
And on that note, so are there other treatments that effectively treat the root cause of all these, you know, pain, depression, whatever it may be, like you said earlier, antibiotics? So what about treating the root cause so people don't have to keep refilling their prescriptions, which are kind of leading them in a vicious cycle in some people's cases, in the case of abuse of painkillers, for example? So can you speak to that?
When it comes to pain, pain is just something that a person has, and it's not treatable. pain medications are just used to alleviate the pain. It's not.
So there's no actual cure for pain other than
There's no
painkillers?
actual cure for pain.
Okay. So that's the position of, I guess, of your organization? I mean, so you're basically...
I don't know if that's the position. It's just there's no cure for pain.
Because a lot of different groups would say otherwise, or have come up with solutions otherwise, and people are getting cured, or I guess the word is cured versus covering symptoms, right? So would you rather focus on the symptoms or actually cure it?
Well, the symptoms are a subgroup of something that's not right in your body, whatever it happens to be.
An imbalance or so, yeah.
Whatever it happens to be. And so I can't speak for the physicians, but my sense is that the physicians are trying to find a solution to the person's problem, whatever that problem might be. And that's why they have different tests, and that's why they might prescribe certain medications. So for example, if you have high blood pressure, there's high blood pressure medications. Yes, there may be some other alternatives, lifestyle changes and losing weight and eating less of a certain
herbs
food.
or medicinal, yeah.
And that's very important, so that now that you bring that up, when a pharmacist is doing a medication therapy management or reviewing everyone's medication regime, they need to know if someone's taking supplements or taking herbals, because that could have an effect on the effectiveness of a medication.
Yes.
So they unintentionally, they may be causing more issues or making things less effective, thinking that they're doing the right thing.
Well, I guess you can't do both. So one with and without the other. So if they're taking all these herbs and then they're coming and then they're taking a Tramadol, it might either cancel each other out or have exacerbate symptoms.
Exactly.
So you should really do what you believe in, because both paths are different. They lead to a different end result.
But I think you have to, when you're talking to the pharmacist or the physician, you have to really elaborate on everything that you're taking.
Right.
So that, because it may seem insignificant to the patient, but it may have a very significant impact.
Yeah, and again, it's just really, really getting to the root of the problem, which people are after now these days, especially the younger millennials, right? So they're finding that pharmaceutical products are not addressing the root of the problem. And in some cases, they're creating a vicious cycle, which is where we get into the opioid crisis, right? People are dying, or they're addicted, or they're getting, other organ failure, things like that. So what about the patients who are actually looking for doctors who will just keep renewing their pain medication continuously? What would you speak to that?
So I'm sure that there are patients that are doctor seeking for the drugs, and those are the ones that are addicted at that point. But the doctors really have an obligation to check their history. They can check the PMP, the Prescription Monitoring Program, which is up for viewing. All the health professionals have access to that, and they can actually see when and what type of pain medication.
But anybody can become addicted. So let's just say somebody walked in, a fresh guy, and he was not addicted, but he started to become addicted. So it could actually be anyone. So even by checking their charts, how useful is that in filtering out addicted people?
It's a measure to see how long they've been on it, and to make an assessment to see if they could be addicted.
So then you would kind of stop it if they were on, let's say, more than 6 months, or what would the solution be?
Well, the doctor would have a conversation with the patient to see if they are
Because at that point they might be
addicted.
addicted, yeah.
And there are treatments for that.
So then they would need rehab.
Rehab, or there's medication.
So more medication.
There's more medication on top of this for them to come off of the addiction.
That sounds counterintuitive in some ways. Wow, okay.
Well, I think, with our technology and our healthcare industry, that's where we're at. And
Well, I guess in the long term, would the vision be to get to the root of things, or would it be to continue to develop?
Of course we want to get to the root of things. Of course, always.
Because we're pretty far away from that right now. In this,
I don't know if that's fair to say that we're away from it. I think, as time goes on, we do develop in healthcare, and we're always looking for ways to improve things.
So what about prevention? What are we doing for prevention?
Prevention is pretty much a key to helping avoid addiction, and there's so many ways that one can actually take measures. So, for example, let's take the example of somebody who got into a car accident and was in acute pain and went to the emergency room, and the doctor prescribed an opioid based on the assessments, and then the person went back again and back again and back again. I mean, the measures that the doctor would take and the pharmacist would take after getting some of these prescriptions, we would look into the prescription monitoring system. The doctor and pharmacist can be counseling the patient, and trying to avoid any of that medication getting into the wrong hands. Over the years, it's been noted that most of the pain medications have been prescribed in larger quantities, and I don't think it's any fault of the doctors, or they were taught to treat, to alleviate pain for people, and they want to make them better, but what was happening is, like, some of the leftovers that the people were having were in their closets, and others that have been addicted already might be seeking those out and taking those. And it's important to say that about 50% of the people that are addicted, with the studies that we have come across, have gotten their pain medications from other sources than the doctor.
Mm. But it was created by somebody. It's a drug, really. It's a form of addictive drug. So it's, I mean, where does the burden actually lie? Is it on the patient to make this change? I'm just trying to navigate the future and how to resolve this
Certainly,
big problem.
a patient should take a prescription as prescribed.
But even if they do take it as prescribed, they become addicted. That's the nature of the beast, and that's where the problem is.
Well, not necessarily, and not all the time.
It's kind of
Some
like saying,
people
well, take marijuana, but don't get addicted, or start chewing tobacco, but you can't take it more than once a day or a week. It's counterintuitive.
Well, again, every medication will affect every person differently. And at some point, the patient has to be aware, or maybe a caregiver or a family member says, it doesn't seem that this is, you're tolerating this well for whatever the reason might be, and report it to the doctor or report it to the pharmacist. It may be that again, if you've gone through medication and it says take it 3 times a day, and you feel that you're in that much pain and you decide to give it to yourself 4 times a day, that's really
Well, that could also mean that it's not working and it's wearing off.
Yes,
so
but you should
you're
call the
becoming
doctor
immune.
and let them know that, because
what would
maybe
they do? Would they prescribe a stronger one?
again, it would be the doctor's medical
I mean, I'm just trying to
decision.
find out what some of the alternatives are. Why do people take this? Because
Maybe a different one would be better for you and would alleviate your pain, a different medication. It doesn't necessarily mean that they're going to go up.
So it's
It might
basically
be
all painkillers. Okay, so they wouldn't have any other
You're
suggestions?
asking us about opioids, so we're trying to respond to the opioid
Well, then the
part.
solution would be to prescribe a different opioid, so it's all.
Possibly another one would alleviate your pain at a lower level.
But
than,
they're all addictive, or more or less, but made the same way. So if the human mind psychologically would respond to all of them, maybe some would have less severe side effects that we spoke of earlier. So it would kind of be like that. You wouldn't really have anything outside of the box solutions or anything at this point.
Again, I think that all of the conversation has to be continuous. If you're not feeling well when you're on a medication, whatever it is, you should let your healthcare provider know it, and ask. Maybe you're taking it with milk, or you're taking it with orange juice. Something that's causing it to provide symptoms that are not generally expected.
Sure, but it won't ever address the root of the problem. Like, there's no opioids out there that would, right? So
opioids are really only meant to address pain.
Yeah.
And pain could be acute, which would be just temporary, or it could be chronic. So those two things will have a bearing on how the treatment plan is laid out for that patient.
That's correct. That's correct in what you're saying, that there are all sorts of side effects, but that's with any medication. It's not
so
just
it's okay
with
then?
opioids. It's with any medication.
Okay.
Every
So
medication
the cost of that
has
is
a
not
side
high
effect.
to the individual or society?
Well, we can't get to a point where we're not going to take any medications. I mean, if you
Well,
have
why
an
not heal?
infection, well,
Yeah.
if you have an infection, an internal
that's
infection,
different.
you're going to need medication.
Sure, if you're dying from,
right. If you
some
have
sort of-
hypertension, you're going to need supplemental medication.
Well,
You
an
can't
infection's
take-
different than hypertension. There's other ways to balance the hypertension.
Right, but
maybe not if a parasite's going to kill you, you have to take an anti-worm medication or something.
Right, but my point is
That's
that
different.
it's not. We cannot become a society that's not going to take any medication because of side effects.
All right, well, I'm going to ask you to hold that thought. We are out of time. We're going to continue part 2 in just a moment here. So thank you, viewers, for watching. Please stay tuned for next week for continuation. Thank you.